Indiana Lyme Connect welcomes Dr. Brad Ralston as part of our 3-guest series.
She wanted me to come and just share my role in Paul's recovery. So first of all, again, my name's Brad Ralston. I have a practice over at 93rd Meridian. It's called Neuro Health Services. And we specialize in functional neurology. I also have an office right next to there at 95th Meridian. It's called Brain Balance. Brain Balance is a program for kids with ADD, ADHD, and autism, which is also functional neurology based. So functional neurology, just to give you an overview of what we do, different from medical neurology, which largely specializes in the diagnosis of diseases of the brain and nervous system. A functional neurologist looks at the function of the brain and nervous system, disease or no disease. So we assess how different areas of the brain are functioning and how they're coordinating together, be it the motor system, the visual system, the auditory system, the sensory system, the vestibular system, etc. Does that make sense? So it's a little bit different. We're looking at this more from just how is the brain functioning? Is it able to receive and transmit information appropriately? Can anybody guess what the main function of the brain is? You said, what is brain function? What is it? Coordination. Okay, that's one.
Oh, that's going to run your body.
Of everything, yes. Run your body. It's to let you know where you are in space. It's the number one function of the brain. So when the brain dysfunctions, you don't know where you are in space. So that could mean cognitive changes, it could mean visual changes, it could mean balance changes, it could be motor changes. All those things can be impaired and affected. So my role in this, and seeing Paul, her slide did a nice job of kind of explaining this. I would come well after infection, treatment, into that rehab part, where if you've had Lyme disease and it's affected things in your brain and nervous system, then and the infection has been controlled, now I go in and evaluate the function of your brain and nervous system to determine if there's things that are dysfunctioning, which obviously there are going to be, and the ways that I can give a therapeutic application to those. The main thing that we're trying to do is isolate the area of the brain that's most affected, that's causing the problem. And this is a kind of a tiered system in the sense that, for example, I'll use Paul. Paul had high fatigability. So he could not tolerate 6 hours of rehab. There was no way. His heart rate would fluctuate between, high 80s up into the 131, 150. So you start doing rehab, and maybe they're not even looking at your heart rate. They're just going, oh, do this exercise. And you're sitting there, and your heart rate's 151, and you're just like, I can't do this. I'm shutting down. They're not. If you're not measuring that, you're not going to know that that person is well exceeding their metabolic rate. So you're better off to just, with Paul, okay, we're going to monitor your heart rate. We're going to have you do this trivial activity to activate your right cerebellum. We're going to watch your heart rate. And when it rises up more than 20 beats, we're going to stop. And we're going to continue to do that until we build plasticity in that system, and then we're going to push your heart. So with him, we had to get his autonomic system to calm down. So he spent a lot of time riding our tilt table, which is tilting him up and down and just letting him feel gravity, letting him come up and let his cerebellum, be under stress of gravity, letting his heart rate come up. And then when it gets too high, then just lower him down a few degrees, let him sit there. And that builds plasticity of the nervous system. Does everybody know what plasticity is? Everybody heard of that term? Okay.
Not really.
Plasticity is the ability of the brain to remodel itself, to change itself. It's where you build new neural connections. And it's really the basis of neurological rehab, is plasticity. It's the basis of learning. So any system undergoes plastic changes, either positively or negatively, it's building new synaptic connections. Trauma and things like that can build abnormal or pathological plasticity. We want to build beneficial plasticity into areas. So when there's neuronal pools that are unstable, like in Paul's situation in his brainstem and his cerebellum, we have to build plasticity there before we can get him to do more complex things. If you can't stand and close your eyes and keep your balance, then I can't stand and have you stand and do rehab. Doesn't make any sense. You're going to have to lay down and do things laying down for a while until you can control that aspect, and then I move you to seated and then move you to standing. Okay. So we're going to look at this slide presentation. Let me just say right off the bat, I'm not a Lyme disease expert in regards to the infectious disease part of it. You guys are well more knowledgeable than that. I'm looking at Lyme disease as a chronic condition. A lot of the features we see are honestly a lot like a concussion. It's just the immune system has concussed the brain, or the infection has affected certain parts of the brain in a negative way. And so a lot of the compensatory reflexes that we see in the brain are much the same as we see with a concussion or another chronic disease such as chronic pain, fibromyalgia, etc. A lot of times people go to doctors and they are told that there's nothing wrong with them. They have a normal neurological exam. Then your MRI is completely normal. You're fine. But obviously, we know that there's a lot more going on than just what the MRI says.
Or the EMG.
Right.
They don't show anything. Well, my experience is
EEG? Yeah. So with any chronic condition, we see, like Leanne had described, cognitive, physical, GI, autonomic, adrenal, immune dysfunction, which can be characterized by a large number of symptoms that can be all over the place. We find that the more symptoms that a patient has that's all over the place, the more it probably points to the brain. Because the brain controls it controls all functions, including hormonal, immune, autonomic, etc. So, chronic symptoms are real. They are reversible. They don't always respond well to medication. Obviously, we support the use of medication, but sometimes they're just not great for the difficulties we find in patients like this. Dysautonomia, there's some medications that work well, but sometimes you have to make the brain do something different. So the biggest thing that we see when the brain dysfunctions is an upregulation of what's called the fight or flight system. Everybody know what fight or flight is? Okay. So in your brain, you have three levels of your brain stem. The top area is called the mesencephalon, or midbrain. Then you have the pons, which is in the lower brainstem, and then the medulla is the bottom part. So we characterize it as mesencephalon, and then pontomedullary under that. Right? The mesencephalon is fight or flight. The pontomedullary is rest and digest. So there's a conflict between rest and digest and fight or flight. And so when your brain becomes injured, be it a concussion, be it a migraine, be it a inflammation, hypoxia, low blood sugar, infection, it's going to upregulate the mesencephalon and cause this increased fight or flight response. So the first thing we look at when patients walk through the door is we're seeing if they're in fight or flight. Is their heart rate up? Respiration's up? Pupil enlargement or coarctation, dilation of the pupil, increased reflexes, increased adrenal stress. Think we see those in Lyme patients?
Yes.
So the fight or flight response is designed to maintain the body during states of heightened stress for short periods of time. So this is your body's way of dealing with stress, and there's a method to the madness. The fight or flight system pumps more blood to your brain to keep it going. So we'll talk about how we compensate for that. But these are the things we see on examination, which obviously we saw these things with Paul. We've seen with a lot of patients with chronic symptomatology is just lots of high heart rates and pupil dilation, and their brain is just on fire. As a result, with the lower brainstem underfunctions, it impairs digestion. The gut starts to dysfunction. Your bowels don't work right. Sexual dysfunction, dry mouth, tearing issues, blood supply to organs goes down. And some of this, what we talked about with neurogenic bladder. Pontomedullary area is key with integrating the sympathetic and parasympathetic system across the spinal cord, which affects the contraction of your bladder. So people who have high sympathetic tone, they can't empty their bladder. Their bladder doesn't empty correctly, and then they get stasis of urine, and that sits around and gets infected. It's kind of like why back in the day they wouldn't let, they didn't want little girls to take hot bubble baths.
Yeah.
And it was because it caused the UTI. Well, it causes the UTI not because of the soap, it causes it because of the heat. You heat these kids up, their bladder doesn't empty. They don't go to the bathroom as much. So that's designed to make your brain, like if you're in say a stressful situation, you got to run away from a bear. You don't be like, oh, I got to pee. You want to hold on to pee, you just got to get out. So, we see this top-down control from the brain. Literally every organ system, every output of your body is synaptically relayed back to the spinal cord and brain. So as Leanne was saying, if there's specific nerves that are damaged, we're going to be able to look for those. And sometimes you just got to teach the person to adapt and find a different strategy to compensate for that. But sometimes I've found that people have said that the nerve is damaged, and it actually wasn't damaged. It just wasn't functioning. There was something that was affecting its overall function. Okay, so the brain normally fires, again, like we said, the left brain fires to the lower brainstem. The right brain fires to the right lower brainstem. Information that's coming up from your left side hits the left cerebellum and is relayed to the right brain. Okay. Then the right brain fires back out to the right lower brainstem. Does that make sense? So everything comes in from our body and is relayed to the contralateral side of the brain. The brain fires down ipsilaterally to the lower brainstem. This gets disrupted when there's changes in integration from the cerebellum to the brain. So when the brain decreases its output to the lower brainstem, then we see overfiring of the upper brainstem or mesencephalon. So this can come from decreased cortical output, increased cerebellar output, or it can come from issues specifically in the mesencephalon. Like we talked about, hypoxia, low blood sugar, inflammation, infection can definitely do that. But generally, it starts to take a toll on this overall normal firing of the brain. And you see those compensatory sympathetic reflexes start to pop up. So any type of trauma, physical, mental, emotional stress, toxins, chemicals, or infection can cause that dysfunction. That altered brain firing creates chronic pain and chronic fatigue, migraine headaches and light sensitivity, blurred vision, increased sweating, difficulty falling or staying asleep. When the brain stem's overfiring, you start to get this insomnia, you start to clench your teeth, sometimes TMJ, heart palpitations. We see that a lot in patients. Irritable bowel syndrome, UTIs, high blood pressure, brain fog. As that loop continues to increase the firing from the mesencephalon. Cognitive behaviorally, we can see episodes of depression, anxiety, difficulty scanning pages when reading, difficulty adding or subtracting, difficulty expressing what you say, difficulty understanding what others say to you, loss of long or short-term memory, loss of sensation or numbness, changes in handwriting, or irritable or angry, problems with balance, tripping, dropping things, ADD, dyslexia. Okay. This is more when the brain, when we're talking about the cerebral hemispheres are affected. Okay. So, kind of a different view of that, but it's all the same problem. In particular, when the mesencephalon is overfiring, we see increased pupil diameter, which lets more light into your eye. That causes light sensitivity, which is a very common symptom that you see in patients with chronic symptomatology. Think of like a camera lens. If I open up that lens more, I'm going to let more light in. That's what creates light sensitivities. When you look at people who are light sensitive, you see these big pupils. The blood vessels in the brain can constrict and dilate, which is where you see headaches. Some people have vasodilated headaches, meaning the blood vessels open up and blood pools in the brain. Some people have more vasoconstricted headaches. Sometimes, like your response to like caffeine can tell you about that. Does anybody have headaches? You do well with caffeine or not?
I do have it.
You do have it? You don't have it?
She's not allowed. I'm not allowed to. So I was so moved.
Zomig? Yeah. Okay.
For me, it's dose dependent. If I get too much, I get a very bad headache. If I get right in my sweet spot, it helps the headache.
It's kind of like you got to get it right as soon as that starting, get some basic constriction going. Sometimes you can ward off a headache. But the lower brainstem not firing definitely affects the NTS, which is nucleus tractus solitarius, which has an effect on bladder function, and the vagus nerve. So the vagus nerve is very, very big in research with chronic pain. Everybody know what the vagus nerve is? So it innervates everything, comes off your lower brainstem, this cranial nerve 10, innervates everything from your heart to your lungs to your colon on down. So with chronic pain, we do a lot of vagus nerve stimulation. Now they do this electrically. They can put in a vagus nerve stimulator. It's commonly used for patients who have intractable seizures. We use a non-invasive form of vagus nerve stimulation electrically. We like to do 15 to 20 minutes of that 3 times a week. Sometimes we get the patient to home unit, just have them do it at home. It has great outcomes with chronic pain and dysautonomia. So, go ahead.
Why would stimulating it? Isn't it being overstimulated?
No, the vagus nerve is, because the midbrain is overfiring, remember the midbrain is the top,
So it's not stimulating.
the lower brain stem is not stimulated. Yeah. So when you stimulate the vagus nerve, it calms, it increases rest and digest.
So I read you can exercise it by humming or making a specific noise.
Yes.
You're going to have patients do that.
Gargling, rubbing your tummy, things like that. There's like a little Facebook, one of those things. 33 ways to stimulate your vagus nerve. Humming, gargling, things like that. Some people like do hard swallows, gagging, palatal stimulation, all those things. But the mesencephalon being high also increases your cortisol responses. So as Leanne was talking about, adrenal dysfunction is something we see commonly where cortisol levels become affected. A lot of times what we see is a rhythm problem with cortisol where it gets too high and too low. So a lot of times people start off the day with too low cortisol. At night, their nighttime cortisols are too high, so they flip their circadian rhythms over and they can't fall asleep.
What do you do with that?
You typically have to get at the brain, because the brain is what tells the adrenals what to do. If it's a rhythm problem, a lot of times it's the problem centered in the hippocampus. So the hippocampus is in the temporal lobe, and it's this little seahorse thing that does short-term memory, and that's the kind of the
So you have to reprogram these?
through.
What specifically do you do to reprogram that patient? I know a lot of people use phosphatidylserine at night to dampen the cortisol, but your approach is what exactly?
I would use phosphatidylserine too. It's great for the canvas. It's like a food for the canvas, but also brain-based therapies to try to downregulate those.
Like when you say brain-based therapies, what exactly does that mean? Are you attaching something to your head, stimulating
It might be
Are you-
vagus nerve stimulation. It might be vestibular and oculomotor rehab. It might involve breathing exercises or a host of different things. Whatever your issue is, we can address and see if we can. What you want to try to do is fire up the brain so that it fires up the lower brainstem.
So then, what if you fall asleep later on? I can up always at 3 a.m. I can fall asleep fine at the clock, but it's the same idea.
Yeah, I mean, I'm not addressing you, but I mean,
Right.
sometimes that's serotonin based or blood sugar. I find a lot of people wake up at night because they're hungry. So if high cortisol, you burn through glucose so fast. And if you get hungry, it'll just be like, oh, I'm not thinking. Most women don't realize this because
Yeah, I don't
Me?
get up and eat.
me, I know I'm hungry.
Okay.
You say you don't
I don't get up and eat.
get up and eat. I can tell.
Try to sleep.
Yeah. That's what most people do is, but try it next time and you go, am I hungry? Is that what the problem is?
Try to eat something that's easy to digest.
So-
Otherwise,
Well, then I'm gonna have god-awful
Okay.
reflux and
Right.
it's still going.
Yeah.
So, so the higher cortisol is what's preventing the ability to get to sleep?
Yes. Cortisol and melatonin are inversely proportional. So the higher your cortisol goes, your melatonin goes down. So you're not going to be able to fall asleep. But back to that previous slide, the vagus nerve. Think about too. A lot of people who we see with chronic symptoms have bad tummies, dysbiosis, leaky gut, and those types of things all play into this too. And that leaky gut feeds right back up to the vagus too, right back up into the brainstem, which further causes that brainstem issue. So through the IML and the sympathetic cord, we have influences in the SA and AV node, which affect heart. So if you have basically if you have a left brain type problem, you're more likely to have like PVCs and PACs, whereas if you have a right brain problem, you're more likely to have tachycardia. So high heart rate people typically have that right brain type of.
May I ask you a question? Does that relate to flattenings and inversions of T waves?
It can,
We
yes,
can,
yes.
because that's what, I know, in my heart, I've been diagnosed with the flattening and inversion. Then there was something else, but I don't remember what that was.
Yeah.
And something else came when I got diagnosed with mycoplasma infection.
Yeah, there's some of our colleagues, so just kind of a segue, I did my training at the Carrick Institute with Dr. Ted Carrick, who's a world-renowned functional neurologist and basically the father of all this type of work. All of us are following in his footsteps, and he first pioneered this work in the late 80s and early 90s. And he's just a wizard. He's brilliant, and he gives a lot of lectures on neurocardiology. I have an understanding cursory, but he's really good at that stuff. But yes, there's a lot of influences with the IML on the heart.
What's his name again?
Ted Carrick,
I spell his last name.
Carrick.
Thank you.
And so another group to research is called Plasticity Brain Center. We're all connected in this neuro network of providers throughout the country who do this type of work. So our training, again, we started with Dr. Carrick. I started back with him in 1997, learning from just have morphed into different, I would say, specialties based upon, the needs that we find. Concussion was obviously a big need, so we really researched and dove into that a few years back. I'm guessing that Lyme disease would probably be somewhere on the forefront, given the prevalence. Looking at emotional stress, a lot of what we look at with disease, with chronic symptoms, with concussion and things like that is that we see effects into the pituitary. So the pituitary is going to release all your releasing hormones. So if you have a concussion, you're going to see a hormonal change with patients. If you've had Lyme disease that's affected your brain and downregulated your pituitary, now you're going to have hormonal problems. It only makes sense. Your thyroid, your pituitary, all these glands are basically registering almost like a thermostat, how your metabolism needs to be turned up or down based upon what you can tolerate. If you can't tolerate anything, your brain's just going to turn down the thermostat. So the pituitary downregulation is where you're going to see these hormonal changes.
Do you do, as part of the therapy, you start with baseline measurements?
We do sometimes. It depends. I don't have anything that I do hard and fast. Everybody comes into this with different specialties.
I'm thinking if someone had.
Yeah, absolutely.
That would be.
Yeah. Mm-hmm. Yep. So some of my patients, I guess we would say, they come in with all this stuff already done. So I'm not going to recreate the wheel. And, if they have, say, a functional medicine doctor, or they're seeing maybe an MD or something that's handling that, then I'll do my piece. I really like to stay with the functional neurology side. I do have a functional medicine doctor in my office.
Do you turn people away to get your over 90%?
No.
That's right.
Or do people
I make
divorce
them.
you?
Right. I make them qualify.
They leave on their own.
I'm sorry, I'm a super
Asking that
critic.
question.
I am a super critic. I'm super critical.
Well, it depends on what,
We've been through a lot, you have to understand.
Oh, I understand. No, I know.
Okay, I'm good.
Well, I want to interject. What I appreciate about Dr. Ralston, he did stick to his piece. And he said to me, I really don't know that much about Lyme. And because I have been to other chiropractors and they were trying to treat Lyme. And I knew probably 90% more than they did. And you all understand what I'm talking about. I appreciated that he understood the disease part. And until we beat down that disease, this healing couldn't help us. We needed to use the medications we were to get through it. And he really said, I don't know how much I can give back, but I see this and this and this part, and I can explain this, this, and this, and let's work on that. And that's what I really appreciate, his humility. And the parts that we worked on were really, really helpful. And when we came to a part that didn't work, he agreed we needed to look for another source. So just to speak for that. Yeah.
To that, and I think that's a great point. As someone watching someone go through this, both of us are impatient. Okay? And so when we see, hey, I can impact these symptoms, of course, we all want to do it like now, right? How do you determine when's the right time in diagnosis, treatment? Because they're not hard stops. It's not like you do treatment for exactly 6 months, 12 days, and 4 hours, and then you take next step.
Sure.
So how do you navigate kind of that time where you're not sure?
Some of it comes naturally, like when the patients are on treatment or off treatment, we might find that there's a good week for me to work with them, and then like if they're getting treatment, that
I got you. The pulse cycle. That makes
and
sense.
it's like okay, this is just not working.
Yeah, I'm thinking more in our particular treatment is 3 years. They're trying to kind of get it down. We know there's damage, and it's just a matter of wanting to apply healing techniques that you appropriate time. Because I don't want to, we both don't want to add stress. So kind of, is it an art as opposed to a science, basically?
Yeah. But what we're looking at is something really specific. So we're going to get into what we're testing and measuring here. But we use some different evaluations. One is dynamic posturography, which is a balance assessment. It's a test that you stand on a forced platform with your eyes closed, and we measure your stability. So stability is a huge thing in regards to, back to my original premise, where you are in space. So if I see that stability number really down and you're fatiguing a lot in the test, then I know that you're probably you're not in a good place to do a lot of brain rehab today. Yeah. We look at those autonomic measurements. We look at your heart rate. We look at this examination, and if things are you're blown up, it's like, okay, this is probably not a good day for
Yeah, I
this.
mean, one of
We
the
may do something else.
Yeah, I mean, relative to Lyme, one of
Yes.
the hardest things is you really can't measure the bacteria.
Right.
So you don't know, it's all clinical, you're guessing as to
Sure.
where
But then we're also looking at ocular motor functions, and when we do these tests, we have exactly what we're going for. And so as the patient proceeds through the rehab, their performance should improve, and as that's improving, I'm going to see improvement on the baseline testing.
if
That's
they,
how, yeah. So it's not really geared towards one particular symptom. It's trying to get certain things in your brain to do what we want to do.
symptoms
Go ahead.
Yeah, Lynn, we've had these conversations because we were in that position too, and we wanted so bad for just success. We tried things too early. And it really came to our Lyme provider. He would say, the disease is winning too much. We're still in too much of an active state. So whatever you're trying to quote rehab is just, you're still dealing with this bacteria. There's a time for it. And so using the provider, wherever you are, and they're finally saying you're kind of more in a maintenance stage, that's when we saw the biggest thing. That's when we saw not the complete setbacks. And then when we were in treatment, as Dr. Ralston found, I mean, there was no point of bringing it all in.
I mean, it's,
But if we had brought him in probably a year before, there was no way. He wasn't ready.
and that's the concern.
So when your Lyme provider says you're kind of in that maintenance phase, that's when we found it was time to start.
And like,
Thank you.
Oh,
and at the end, maybe you could talk a little bit about, for example, kind of like with me, what a session kind of would look like, and how things would adjust based on the day, based on minute by minute.
Mm-hmm. Right.
Thank you.
Exactly. So as I was saying, dynamic posturography is something that we use in our initial testing, and we use as an ongoing measurement of your performance. So I'm going to kind of segue due to time, based upon go into more of what we're testing for, and then go into more of the treatment protocols. I think we've established, how we're looking at different effects of Lyme on the brain. So dynamic posturography, you're basically standing on a static platform and then a dynamic platform, which is a foam pad which perturbates you and makes you off balance, and you have your eyes closed, and we see how you compensate for that. Okay. It's a great standard measurement of overall neurological function. Then we go in and look at the visual system. We're looking mainly more at the ocular motor system than the visual system. The visual system being more like, how do you see 20/20 eye doctor kind of stuff is more what I let them handle. I'm looking more at how the eyes are functioning together, because your eyes are connected to your inner ear, through the vestibular system. So all these types of eye reflexes are important to me, and then the neck. So your neck, your inner ear, and your eyes are vitally important for you to maintain balance and for you to maintain what we call gaze stability. Your ability to hold your eyes on a target for a sustained period of time. When the brainstem is under functioning, one of the biggest things we lose is gaze stability and gaze movement. Paul had a lot of this, something he worked on quite extensively and did a great job with. But again, be patient with it. So if I hold a target 20 degrees out to the left and I have you focus on it, I'm looking to see, do I see any movement of your eye off the target? Are you saccading towards the target? Are you saccading away from the target? Is your eye really struggling to stay out there? If you can't do that, then it's very hard to read. It's very hard to be in public spaces where your eyes are jerking around. When your eyes jerk around, the background moves. It can be very disrupting visually, and it can make you feel very insecure. So a lot of the patients we see have this insecurity with their visual system because their eyes have all these little saccadic movements, what we call square wave jerks, that shouldn't be there. And those make you feel
I'm sorry, what are they called again?
square wave jerks.
Square wave jerks?
Square wave jerks. So on testing, they look like, it looks like a square.
Because it happens whenever I write sometimes, and I'm not writing for very long, and it's so frustrating. It used to happen, and it never used to happen.
Disrupts a lot of cognitive functions. Reading, writing, trying to focus, and you're looking at a target, but your eye is making those little jerks. Yeah, that perception definitely. So that's all affected in through the eyes, deep down in the brainstem, in that lower brainstem, and that pontomedullary system is where gaze holding takes place. So impaired eye movements indicate suboptimal brain function beyond the influence of depression, malingering, and intellectual ability. So these studies basically all show that, in concussion, we see these aberrant anti-saccades, saccades, memory-guided saccades, smooth pursuit, gaze holding, all these things that really nobody's testing and measuring. But they're there, and that's what the real problem is with recovery, is that all these little eye movements that you're not going to see, this far away from the patient. Oh, you're fine. You have to really be looking at that patient to discover these. Eyes turned in, eyes turned out. Almost everybody that I see, their eyes will be shifted one way or another. So instead of the eye just, looking straight out, I'll see rotation in or out on one of the eyes. So your brain is not receiving the right amount of information. That's called strabismus. Another thing we oftentimes see is convergence problems. Your ability to bring your eyes in and out becomes lost. Very hard to read if you can't hold your eyes in convergence, or if you have convergence overfiring or convergence spasm. So all these things affect clear vision, getting your eyes to go the same direction. Anybody have problems with clear vision? And most of the time, as the eye doctors say, your vision's fine. So it's obviously in the way your eyes are moving. If I take my eye and I just go right in there and I just push it just a little bit, I'm going to get blurred vision because this eye is going to be turned.
What is that when, like, one eye, someone I know has one eye that's smaller and the other one's really big, that they went in really heightened times of inflammation? What is that? Is that related?
Mm-hmm. Yeah. The pupil or the whole eye?
The pupils are always dilated, but I mean, the actual lids, like one's big and one's smaller.
Yeah. They get a ptosis on one side and then the other eye props open.
Yeah.
And that usually is the side that the sympathetic system is like really going crazy. So with those patients, we like to do like bilateral blood pressures. Generally, you'll see the blood pressure on the side of that big O eye like way higher and things like that. They may sweat more on that side. They may have differences.
Can you comment on the sun and its effect on the eyes? 'Cause, like, middle of winter, I went out and I did a women's march, and it was a beautiful sunny day in South Bend. It just exacerbated my symptoms because I saw the sun for a couple of hours. So is that, do you know why that is? And what's going on?
Was there snow on the ground or was there a lot of
I don't think
contrast?
so.
I mean, just.
I had just hadn't seen the sun that long. It was like a 60-degree day.
Yeah.
It was in January. So it's like, I always knew that the sun trigger for me.
Yeah. Yeah.
I
Light
just don't know what
sensitivity.
system it's working on. It's gotta be something in the visual or brain.
Oh yeah,
you know.
definitely working on the mesencephalon.
Yeah.
And so, but different people, I think, react to different things. I have some patients that just cannot tolerate like these lights on there, they're like the fluorescent, really harsh fluorescent lights, just fire them up. Some patients can't tolerate computer screens, can't tolerate computers at all. But anytime we see, strabismus or nystagmus or eye dysfunction, oftentimes what we'll see is head tilt. And the head will shift and tilt, where you're compensating, and your eyes are actually on two different planes. And so if this eye elevates, what I'm going to do is tip my head this way to line up the visual field. So anytime you see a head tilt, you already know that the eyes are out of balance. Head postures, strabismus, where you see the in rotation of the eyes, the way they roll side to side, are things that we all look at. This little guy, this eye, he's got a hypertropia. It's deviated up. He's tilting his head to the right. Obviously, she's got a big hypertropia.
And you're saying you have strategies that work on the brain can help alleviate that?
So what we use is called video nystagography. We put some goggles over the eyes, and we watch eye movements. And while you're actually watching like a light bar, and we are projecting that onto a computer screen, so we can measure and graph out how your saccades, your pursuits, your optokinetic movements are, your gaze stability, your gaze holding, all those things are working. So we have an objective measurement of your eye movements. That's a permanent record for us. Part of what we do with the rehab is we program your exercises based upon how you performed here. We do rehab for a prescribed period of time and then repeat this test to make sure that we're seeing the change objectively with your eye movements. I wanted to bring Paul's pre and post.
It's unbelievable.
So you sit, you wear the goggles, and then there's a light bar that's projecting different things, different dots and bars. That's how we test the eyes. So we use the dynamic posturography and the video nystagography to get an assessment objectively of how your nervous system is performing. So it graphs it all. Another thing we look at a lot is the vestibular system. You guys familiar with vestibular function? The inner ear systems? Okay. So the vestibular system is encased in your inner ear. Your inner ear has receptors that respond to rotational movement and translation, which is up and down or forward and back. Okay. So the otoliths and the semicircular canals tell you where you are in space based upon how you're moving. Lots of patients have abnormalities here. Patients who we see that have balance problems, motion sickness, a host of other different issues in regards to inner ear function, we will want to assess the vestibular system. We worked a lot with Paul's vestibular system. Patients can't stand on the caps and do the dynamic posturography. We know the vestibular system's been affected. Okay. Now, infection can do that. It can affect these hair cells and these receptors in the inner ear and cause vestibular damage. Oftentimes, those can still be taught to compensate. What we've started to realize here recently, this is like 10 years worth, meaning new information in the last 10 years, is that the cerebellum has a lot to do with cognitive function. And so it used to be thought of as just primarily, your cerebellum is in the back of the brain, thought primarily as a balance, coordination and movement type of organ. We know has a lot to do with cognition. So emotional symptoms can come from your cerebellum being dysfunctional. So a lot of patients with these cerebellar-based problems have a lot of emotional symptoms, psychiatric issues. So vestibular dysfunction has been shown to adversely affect attention. So demands can worsen the postural sway associated with vestibular disorders. MRI studies show that humans with bilateral vestibular damage undergo atrophy of the hippocampus, which correlates with their degree of impairment on spatial memory tasks. So a lot of different studies looking at the cerebellum and cognitive function. Some of the things we work on in rehab: gaze stability. Again, the ability to hold your eye on the target and not move away. As we're doing gaze stability exercises, we may have the patient then look at the target and then start to move their head side to side. We watch their eye movements to see how they're able to hold and track that. We want to see, does it stay clear or does it move around? Does the patient show any balance problems when they start to do these exercises as we move it around? Vision perception is based upon incoming sensory signal information about ongoing activities. Recordings from single neurons have shown that corollary discharge signals can influence visual representation in the parietal, frontal, and extrastriate cortex, as well as the superior colliculus. So the neural circuitry that produces remapping is distinguished by significant plasticity, suggesting that updating of salient stimuli is a fundamental process for spatial stability and visuospatial behavior. Things that we see with concussion, Lyme disease, with patients with chronic disease is that they lose this visuospatial and their body-centered awareness of where they are in space. And that can be very frightening. It can be very difficult to manage if you feel like you're not grounded and you don't know where you are in space. And so the superior colliculus is a key area that works at mapping where you are in space again. It's a specific rehab protocol that we do that helps remap the visual system so that you know, again, where you are in space. A lot of these are controlled by parts in the brain that control different eye movements. The frontal lobe controls saccades, basically. Saccades are fast eye movements, like this quick back and forth eye movements. Pursuits are more back here in the parietal lobe. Pursuits are slow pursuits, like slow eye movements back and forth. Back here in the cerebellum, you'll see the vestibular ocular reflexes, that type of reflex. When we're testing and we're seeing aberrancies, say for example, in one of these eye movements, what we're doing is trying to ascertain, is that paramount to what symptoms you're presenting with. So say for example, the front part of the brain, does everybody know what the front part of the brain does? Emotion. Concentration, planning, judgment, emotional expression, creativity. Front part of your brain is the human part of the brain. So when people have depression and they have problems with learning and things like that, that would be in the frontal lobe. The parietal lobe is associated with like sensory information, motor sensory. Okay? So if you have problems moving your right arm, would I look more at the front part or maybe more at the motor areas? Okay, so I'm looking at the motor areas. If the motor areas control smooth pursuit and this controls saccades, which would I better be looking at in regards to eye movements to try to figure out what's wrong with you? Your pursuits or your saccades? Your pursuits. So I see aberrant pursuits and I see aberrant motor activity. I'm piecing that together. Now if I rehab you, and I have you do motor activity combined with pursuits and we rehab that area, I can see how that area of the brain is doing. That's how we piece together the diagnosis. Another key area of the brain and nervous system that we focus on is the basal ganglia. Basal ganglia, does anybody know what that's involved with? Parkinson's. Okay, it's a dopaminergic area of the brain, and it is influencing motor and emotional regulation. Stopping and starting motor activity is largely geared by the basal ganglia. So we have an on pathway and an off pathway. Most movement disorders are an aberrancy in have tremors and when you have tics and when you have all these different things that can come out and as movement disorders, largely it's the basal ganglia that's involved.
So let's go.
So with strategies, we focus on balance training, peripheral nerve stimulation, and visual cues. We may do peripheral nerve stimulation to nerves of the body that we're finding that you're not moving correctly or that you're not getting good feedback from to the brain. So say you have a sensory loss from your lower extremity, you're not moving your left side appropriately. We want to maybe electrically stimulate your left lower leg so that the right brain knows where that is in space. Okay. Does that make sense? Vagus nerve stimulation. We may use that for somebody who has a heightened mesencephalon or fight or flight response. SSEP is another electrical stimulation that we do through the tongue. So we use a little electrode that goes right into the tongue, and it kind of shocks the tongue to stimulate the gaze holding centers. Paul can tell you all about it. He's had hundreds of them. And it just vibrates the tongue, and it's an electrical stimulation right into that gaze center.
It's like looking at a battery.
Yeah, sort of.
Oh, I do that all the time.
And you do that because why?
Everybody knows that.
You will do that? You will like batteries when we were kids.
So typical like rehab, what we would do is after we diagnose and come up with our treatment goals that we're going to focus on. Say for example, a patient comes in, and I can use him as an example. Okay. So as he came in, his balance was poor. There was decreased proprioception coming in from his muscles and joints, mainly kind of just the tone and the disuse atrophy. There's just decreased feedback into the cerebellum. There was obviously the dysautonomia. His heart rate was really high. Pupils were big, and lots of fatigue. So we knew that we had to deal with the brain stem in order to decrease his fatigability and get him autonomically stable.
And the oxygen was really low.
The what?
The oxygen.
Yes, oxygen levels. His pulse oxes were
88.
Yeah, right around 90. Ideally, you're going to see 97 to 99 on most patients all the time. His were really low. So we had to do a lot of deep breathing. Just counseling on breathing exercises. So we put a band around him and had him do some deep diaphragmatic breathing, supine, for a long period of time. And Paul learned to breathe up his own oxygen levels. He just looked at the pulse ox and he could do some deep breathing exercises and bring that up. So once we got that working, that was helpful for him. We did some soft tissue things with him. He had some neck complaints and some headaches, obviously, that are still ongoing. But we used some different techniques on there. We did some SSEP stimulation to activate the lower brain stem, activate the vagus nerve centers, and then we started in some gaze stability protocols with him. So getting his eyes to be able to hold, his eye movements were, he had a hard time at first. All his eye movements were, had been impaired and affected. So we want to start from kind of the baseline, which is gaze stability. You can't do anything if your eyes are going to jerk around with any other eye movements. So he did a lot of no, yes type of exercises, supine and standing. I'm sorry, laying down and then sitting up. And then while we did that, we combined that with the tilt table. The tilt table is just a table that just comes up in different degrees. We'd lay Paul down, we'd look at his heart rate, we'd tilt him, we'd just let him sit there and do different activities with him to see if we could lower his heart rate while he was on the table. So we might do complex movements, or we may use a Hemi field, or we had like a checkerboard on one side and give that to him. Yeah, that's the tilt table. So we're monitoring his pulse ox, watching his heart rate and his breathing. He didn't have the band on at that time, but definitely focusing on those deep breathing exercises while he was doing that, and his oxygen levels.
Can I say something?
Go ahead.
You know, with Lyme, how it's really hard because you don't have concrete measurements for things, right? What I really appreciated about this, first of all, when Dr. Ralston said, of course he can't read. You know, if your eyes can't even work, you're taking in information. And by having some of these measurements, you could visually monitor it. You could see things. Like when he would measure Paul's his heart rate and his oxygen, and I'm seeing 88 oxygen. You know, Paul was hospitalized if his oxygen was under 92, but yet he was living like this. And so with Dr. Ralston showing us, there were visible signs that helped us see what we needed to do and not do in treatment, and to see that completely change. Now, instead of 3 months, it took a year and a half, I think, 18 months, which normally maybe over 3 months. But you know what? As a, you know, coming from this, it's really nice when you have something concrete and visible. And so I wanted to say that was really, really helpful to me as a mom that he did that.
I agree. My daughter actually was with you for 3 months, and it was a lot of improvement. I mean, she never lost the ability to read, but she would read for maybe an hour and just have a crushing headache because she had that eye movement thing, and you don't know you have your eyes doing this. You don't realize it, but you get massive headaches if you read any length of time or whatever. And so she, through whatever, all this stuff that you're now saying that you did with her, her migraines were almost gone at that point. And it's been, about a year and a half since we've been back. And her migraines are occasional, but not too intense. She's, since we last saw you, she's probably finished 3 college courses, and is able to read, and she's got a part-time job now. I mean, it really helped a lot. Her stamina was helped. Reading is not an issue whatsoever. In fact, she has regained the love of reading and is just reading novel after novel on top of taking courses. You know, it's been very exciting. So, yeah.
Thank you.
There's
I
snap
appreciate
update.
it. Yeah. Good to hear she's doing good. And that's kind of like something we'll segue to is just, you know, when you're looking at this V and G, you have that picture of you in the goggles.
Mm-hmm.
It's
So attractive.
Right. We test and measure that often to see how the eye movements are doing. If you start off and you have like poor gaze stability and you can't pursue and you can't do a movement called optokinetic, which is where your eyes are moving back and forth, then reading is not going to be very fun. It's not going to be easy. And so he wears these, and then the light bar is right here, and so we tested, as we saw earlier, and through our treatment, Paul's eye movements just became outstanding. And as that starts to improve, the reading levels start to come in. And that forms the basis of what we're able to do later on, which is come in and build on things cognitively. So much of Paul's early treatment was just based upon autonomics, getting his eye movements up to speed, so on and so forth. As he finished, you know, Paul, he's incredible as far as his desire to get better and improve. And I almost felt like pressure every time he came in because he's like, he's going to want more. He's going to want the next step. So once we got through with what I felt like was an intensive enough program to make a change with Paul, there were still some pieces that were missing for him cognitively, which are, you know, way up in the high brain centers. Things that are beyond like what we talked about before. Things in regards to his reading performance, his reading comprehension, math reasoning. He's very intelligent, but he was not functioning at the level of his IQ. So what we did at that point was we gave him what's called a WIAT, which is a Wechsler Individual Achievement Test, and we were able to get some cognitive measures with him. And then we started him on a program of cognitive rehabilitation where we give him very specific exercises that work on the things we found pulled down on the Wyatt to help him specifically with reading comprehension, getting his cognitive endurance up, having him do schoolwork just to build plasticity in his system so that he can tolerate being able to eventually soon here get in, do college courses and be able to sustain his endurance for a long period of time and to study and to read. We knew all that stuff was there based upon his eye movements that he had the potential. He just didn't have the cognitive endurance to do it. So that's what we segued into now. He's just done a great job with that. So that kind of put the icing on the cake, I think, for Paul in regards to his recovery. Wouldn't you agree?
Yep.
And then he did a program called Reading Plus, which is a eye movement program, which he does 30-minute sessions.
Yeah, 20, 30 minutes.
30-minute sessions on eye movements to help just really seal the reading piece back in. So that gives you an overview of the clinic, kind of the approach. Again, I really wanted to try to more present what it is that is dysfunctioning in regards to Lyme disease, to kind of give you guys an overview of the brain and nervous system, to let you know that the symptoms that you have are explainable. Almost every system in neurology, almost every symptom has a biological basis. There's a reason. A lot of times people will say, well, we don't know why that happens. There's a reason it happens. These neurology guys have been doing this for years, and it's a fascinating field because everything that people experience, they know about it. Maybe the doctor you saw didn't know about it, but it's known about. So, and give you an idea that there are some of these disconnected parts are understandable when we look at it from a functional neurology perspective, and kind of give you kind of a glimpse into the brain and some hope as to what you may search for into adding into your rehab to get to the next level. So I'm happy to take any questions you have.
I have a question.
Go ahead.
As far as, I was like sympathetic overload, like crazy when I started all of this. And so I was on loads of medicines to bring me down. And those are cut maybe in half, but I'm still on like Klonopin and all that stuff. Would I still be a candidate for this? I'm still loaded up with all of that.
I mean, most of our patients do come in on a number of different medications. That isn't really a barrier for us to work with improving plasticity and seeing where you're at.
Does it impact, for lack of a better term, movement slow?
No, not really. Vestibular sedatives do a bit. Like if you have an acute dizzy case and they're on a bunch of sedatives, it's kind of like the sedatives are suppressing the function of the brain, and I'm trying to make the brain function. So
It's kind of counterintuitive.
yeah, exactly. It's kind of like if you're taking a bunch of Valium and we're trying to stimulate the brain.
It's not gonna
We maybe just get an even output.
I think I have 4 questions, but I'll just ask one now and give 4. So, in my research, I always thought that it was the pituitary hypothalamus, or HPA axis, hypothalamus pituitary adrenal axis. And my background's in research science, so this is about all I can come up with. So it's just a pleasure to hear that you've hit, what's going on and all. But can you maybe comment on the HPA axis in terms of how it relates with this?
Sure, absolutely.
I can't even say the words you were saying, so.
No, I mean, I think the HPA is central to what we see with Lyme disease or concussion. Again, it's going to downregulate anytime there's cytokines or inflammation or infection, or any type of trauma to the brain. Sometimes there's direct involvement and direct insult to the pituitary. Like in a concussion, you literally can like hit the brain, and that pituitary just lies in that little cella turcica, and it can get physically disrupted, but also chemically it can get disrupted, infections and things like that. And so downregulation of the HPA is really associated with kind of the depression pandemic that we see. Women who have HPA downregulation, may have kind of a puny thyroid, a puny adrenals, puny ovarian output, things like that. So it's a key aspect of research. And getting that going is, can be life-changing for people.
You touched on hormonal imbalances. Do you treat patients that have PMDD, and are you successful with that?
We do address that, certainly. There are some aspects of a neurological basis with that. But, we can talk offline about
Okay.
I would say that I'm not the best at female hormones. I just be straight honest with you.
No experience.
Yeah.
I have extensive experience.
No direct experience.
Exactly. I
Personal.
know about them. It's just that, there's certain aspects of it that, I just don't find my tools are as good as other tools. So if I don't have the tools, then.
Hi, and I'm sorry that I apologize a little late. I had another meeting that I had to attend, but you may have said this, but I might have missed it, so I apologize if I'm repeating anything. So, for somebody who just suffers with chronic fatigue and stiff neck, which are two classic things with Lyme, none of the headaches or anything like that, is this something that could help, or is that a completely different area? Because that's one of my remaining symptoms for the past 6 years. I can't get rid of it.
Yeah, sometimes you have to understand what's causing your fatigue. Sometimes it's, you look at say an adrenal test, or you look here and you think, well, that's the cause. But sometimes your brain and nervous system just aren't efficient. Maybe your heart rate's too high, or maybe your eye movements are dysfunctional, and by the end of the day, your brain's just kind of tired of being awake, and you just are shutting down. So yes, there's a lot of different reasons that would cause that. So, yeah, we can take a look.
And are you taking new patients?
Yes.
Okay.
I am. I love doing rehab. This is kind of my passion, is really specialized in that certain piece of, when I look at somebody's nervous system, I know what I can do for them, and I'm not going to try to do everything that everybody else is doing with them. I'm going to try to add my piece.
I have a question. So something I've experienced, and it hasn't happened in a while, but it's happened 3 times, and it's so super bizarre. So it's like, what has happened is it's like I will get very startled or scared, and then I will have simultaneously intense pain that just happens right at that moment and then goes away. Do you have people that come in and tell you they experience this very often?
Can, yeah. Is your startle response been
Well, my
increased?
spikes is constantly on, and I'm constantly tapping and trying to calm down, breathing, meditating, but it's just not enough.
How's your Moro? You have a Moro?
I don't know. Yes. Yes. Yeah, it's obnoxious.
I won't embarrass you.
I think I embarrassed myself pretty good, so thank you.
So, the Moro reflex, we have people stand, and they hold their hands out, and I stand behind them, and I clap my hands, and they have to cross their arms and then fall all the way back on their arms.
Even talking about this,
Yeah,
I'm feeling
exactly.
anxiety.
Yeah, she's already, you can see her her lips are already she's kind of quivering here.
Yeah.
Her foot's going towards the door.
Exactly. Yeah. And
That's
people will scream. They really get a big Moro. So Moro is a primitive reflex that's buried inside your nervous system. So think about a baby. If you scare a baby, they're like, they go like that. That's what a Moro is. So that Moro, as a result of that sympathetic barrage, you can't get pain.
It's a great description, sympathetic barrage.
Paul said a few questions.
glad to add some things as well.
And you kind of just have to, this stuff it can get so technical. You have to just see it, honestly. You have to, like, you know, look at an exam and see what you're looking at. Because you should be able to feel what it is that we're looking at and ascertaining. And then when it feels different, then you know that it worked because something's changed.
Paul?
Thank you to Dr. Brad Ralston for his time and expertise.